Hey guys, welcome back to another video. So today's video we are answering the question that goes this way: is it possible for you to have vaginal delivery after CS delivery? So guys, if you have not subscribed, kindly subscribe, like the video, share, comment. Don't forget to turn your notification bell so that every time I post a video you will be the first person to be notified. So guys, let us get into the video and see if there are chances, if you had a CS delivery, if you can still have vaginal delivery. The answer is yes, depending on the cause of previous CS delivery. So let us talk about this CS in general, so that you know what can make you first to go for that CS delivery. Why will the doctor decide that this patient should go for the CS delivery and not vaginal delivery? So for because of those reasons, I'm going to explain each and every reason why this type of person can have CS delivery and not vaginal delivery. So CS delivery is a surgical procedure performed under anesthesia in which one or more incisions are made through mother's abdomen and the uterus to deliver one or more babies, or in rare cases it can be performed to remove dead babies. But with dead babies, most of the time the doctor will advise you that you have vaginal delivery, unless maybe the baby is big, it can't pass through the vagina, is when they can recommend birth through CS. So this CS delivery, let us look at some of the reasons why, indications of CS delivery. Why will the doctor recommend CS delivery? And the doctor will recommend this CS delivery if there is maternal condition, if there is something related to the fetus, or if you have both related factors. Yeah. So what are these maternal reasons that can make you go for CS delivery? Your personal reason, or reasons of the mother. Do I say reason? Indications that can make a mother go for CS, and this indication, we put them under maternal indication. So if you had a previous scar, the doctor will advise you that the next delivery you will have, especially if you have two previous scar, or what made you to go for the previous years is the same thing, that is, or it is related with the second reason that you're going that you will go for the next CS, and that the doctor will advise you that you go for CS in case you had a previous scar and there is the same reason relate to this previous reason. Number two, if you have cephalopelvic disproportion. What do I mean by that? If you have a small pelvic, or if you have a big baby is also another reason. But if you have a cephalopelvic disproportion, your pelvic is small and the baby cannot pass through, you will automatically go for CS. If you have we have types of incision. The doctor will decide how to get inside your womb to remove the baby. So they can decide that. Before interruption, I was talking about types of incision. So I was saying that if you had a vertical incision, because of some of the reasons that we are going to look at in this video, the doctor will decide that you go for CS, because if you have a vertical incision, Most of the time we see the doctor giving incision at the lower abdomen, but sometimes the doctor can decide to give a vertical incision. So if you had a previous vertical incision, then the next delivery, because you are at risk of getting uterine rupture, or you are at risk of if you go to labor, you will get a uterine rupture, or you will get you will get other complications. You will just have to deliver through CS. Yeah. Another reason that can make you go for CS is when you have preeclampsia in pregnancy, and preeclampsia and eclampsia, or hypertension, or how depends with how you call it, and you have to save the baby and the mother, or one of them, then you will go for CS. Also, we have contracted pelvis. Your pelvis is so contracted that the baby cannot pass through it, then you will go for CS. We have other, if the in previous delivery, in your previous vaginal delivery, you had fistula, vesicovaginal fistula, or rectovaginal fistula, then the next delivery you will be advised to go for CS, because you are at risk of getting another fistula, especially if it was repaired, repaired. Also, if you have other medical illnesses such as cerebral aneurysm, severe hypertension, severe heart diseases, also you will go for CS. Prolonged labor. When I was in college, they told us that you can, if you are a first-time mom, or if you are a primigravida, the average hours that you're supposed to be in labor is 18 hours. And for someone who has given birth thrice or twice or 4 times, the average hours should be 16 hours. But currently, when I entered into the field, one of the gynecologists told us that we consider prolonged labor after 24 hours. So any labor after 24 hours, or if you have labored for a period of 18 hours, something must be done before 24 hours is what? Before 24 hours elapsed. So if you have a prolonged labor that exceeds 24 hours, you will automatically go for CS. Yes. Another thing that can make you go for CS is if you have pelvic tumors, if you have fibroids, if you have ovarian tumors, genital warts. These are some of the things that the doctor will advise you, that when you are about to when you are at term, you go book for your CS before you start even labor, because they will put you at risk of other complications, and those complications are what we are avoiding. Also, if you have carcinomas, invasive carcinomas are cancers, especially if you have carcinoma of the cervix. Also, that one you will go for CS. Another thing, if you have some of the viral infections such as HIV, hepatitis B, human papilloma virus, those are conditions also the doctor will advise you to go for CS. Another thing that, we also have some relative indications, some relative reasons that can make a mother to go for CS, like postdatism. Most of postdatism, you usually find that some of these babies are bigger. They are bigger. So the doctor will advise you, you can't deliver through the vagina. If you can't deliver a baby who is 5 kg and above, or 4 kg, so 4 point something kg, that is a big baby. It will give you, it will traumatize your vagina. So if you are at that state, then you will have to go for CS. We have also early primigravida, those ladies or those girls who get pregnant when they are still 9 to 12 years or 9 to 13 years. Some of them cannot deliver through the vagina, and therefore they have to go for CS, because we are really trying to avoid traumas and other complications that might set in if you put this mother to go for vaginal delivery. We also have a prior infertility. Do you know the reason why prior infertility will make you go for CS? We usually consider if maybe you have been through other treatments for you to get pregnant. We usually consider that as a precious baby, so we will not put you for labor for longer hours, which will put you at risk of maybe losing the baby or maybe losing your life. Then with that condition, if you had prior infertility, we will consider removing the baby through CS. Also, if you have a bad obstetric history, for example, you are someone who, if you start laboring today, not today, right now, after 2 hours, if that baby is not out of your womb, then the baby will be dead. Yes. Or the moment you start going to labor, you just deliver abruptly. If maybe you have how do you call precipitate labor, we will have to deliver you through CS. And also this bad obstetric history, if you have previous fetal death there, we'll advise you to go for CS delivery to preserve or to save the life of the baby. Yeah. So we also have some of the fetal indication for CS. Those ones that we have looked at are maternal indication. We have fetal indication of CS. So number one, if you have fetal distress. Yes, if you have fetal distress, the baby is not breathing well in your womb, that is emergency CS. You don't have even to sign or whatever. The next step is that the doctor or the nurse who is there should take is to take you for emergency CS. If we have malpresentation, yes, if you have malpresentation or malposition, the fetus is lying in your womb transverse, or maybe the fetus is lying in your womb like this, yeah, oblique, transverse, then the best method to consider to deliver this baby is through CS. We have cord prolapse. Cord prolapse is when the cord is presenting first before the baby and the membranes are ruptured. To mean the time the baby will be passing through the vagina, then it will press the cord and it will do what? It will suffocate the baby. You know, the baby is getting oxygen and the blood through the cord and the umbilical cord to the blood through the placenta. So it means if the cord comes first before the baby, by the time the baby is passing out through the vagina, it will suppress the cord and there will be depression of oxygen and the baby might die. Yes, the baby can die. So at this point, you have to deliver through CS, and it is emergency CS. Yes, it is emergency CS. If you had multiple pregnancy, multiple pregnancy to mean you have more than one baby, more than 2 babies, more than 3 babies, more than 4 babies. You are carrying 3, 4, 5, 6 babies. The best method of delivery is through CS. Also, if you have a big baby, 4 point something kg, also you have to deliver through CS. Another problem, if also you have maybe fetal abnormalities, for example, your baby is having hydrocephalus or sacral tumors or conjoined twins. Conjoined twins are twins born when they are together. So with that, you can't deliver through the vagina. You will just have to go for CS. If you have a baby who is having hydrocephalus, the head is bigger than the body, or it is more big, or yeah, so you'll just have to deliver through CS. Those are some of the methods, some of the reasons or indication that can make a mother go for CS. And you see these reasons, for example, the previous pregnancy, you had the same reason, then the subsequent pregnancy you will have to go for CS because nothing can be done. For example, if you had a cephalopelvic disproportion in the previous pregnancy, the current pregnancy, do you think the pelvic will be large to allow the baby to pass? It won't. You will have to go for CS. So this question that was asked, is it possible for you to deliver through the vagina after CS delivery? The answer is yes, if the previous indication is not presenting in the current pregnancy. Yes, for example, you had malposition or malpresentation in the previous pregnancy. To mean, what do I say by that? What do I mean by that? I mean, for example, the previous pregnancy, the baby was lying in your in your womb transverse, and in this current pregnancy, the baby is lying correctly longitudinal. It means that you will just deliver. The previous pregnancy is you had a big baby of 5.4 kgs, and this current pregnancy you have, or you are carrying a baby who is 2.93 kg. You can deliver. So the answer is yes, depending with the what made you to go for CS in the previous pregnancy. So another thing that I want to talk about is about classification of CS. CS is classified according to site or type where the incision is made, and also according to time. Yes, according to the time. Those are two classifications of CS. And I can say that according to the based on the type of uterine incision, we have two types. Yes, we have incision that is made at the Pigini line. At the Pigini line, most of the doctors, most of the surgeries are done transverse, or they give transverse incision or bikini line incision. And also we have the classical, the one that is being given like this, vertical. So these incisions are made, the doctor will decide which incision he or she is giving to give you according to some of the reason. Like for example, the doctor will decide to give you a bikini line of incision because the lower segment of the uterus form after 32 weeks, and by this it is less muscular, and the active part of uterus and I mean it is muscular and active part of the uterus than upper segment of the uterus, so it heals better. Yes, it heals better. So the main reason for preferring the lower uterine incision is to reduce the incidence of also adhesions. Yes, if you have a bikini line, the incident of adhesion will not set in. Also, if the doctor prefer a classical or vertical incision, this means that maybe you have dense adhesion at the lower uterine segment, or the fetus is impacted. Maybe you have shoulder dystocia, you have maybe it's shoulder dystocia, maybe you are giving birth and the nurse or the midwife diagnosed shoulder dystocia, then the doctor will prefer classical or vertical incision, because it is easier to remove the baby which is impacted at the anterior part of the symphysis pubis through vertical incision. So let us look at some of the advantages of giving bikini line incision. Yes, let us look at some of the advantages of giving bikini line incision. First advantage is that there will be minimal blood loss. If you have been given bikini line incision or horizontal or transverse incision, blood loss is minimal. Also, it repair and heals better. Chances of getting adhesions and scar is minimal. You see, most of the people who have done CS, sometimes you cannot realize until you do thorough physical exam, or until they tell you. And also it reduces the risk of rupturing of uterine rupture when maybe the mother goes into the labor. Also, we have said it also reduce the chances of postpartum infection. Remember, I said that we have two classifications of CS, based on timing and based on the site. So we have looked at based on site of incision, that was classical and bikini line incision. Now let us look at based on timing. So this one we have also two. Number one is elective CS. Elective CS is when you have planned CS, and also we have the emergency one, when now the only thing that should be done is to take you for emergency CS. The only thing that should be done is to take you for theater, take you to the theater, you remove the baby, and everything will come afterwards. So under elective CS, you will have to plan with the doctor and the midwife and the nurses who are attending to you before the day of delivery, or before you reach term. And what can make you plan, or what can make the doctor advise you to go for elective CS? Number one is the pelvic disproportion. I had already explained that the pelvic is smaller than the baby you are carrying, or the pelvic you have cannot allow the baby to pass. Also, if you have a major degree of placenta previa, that is type 1 and type 2, type 3 and type 4. I will talk about those types. Later. Also, if you have more than one fetus, if you have DM, if you have APS, if you have certain fetal abnormality like hydrocephalus, if you have a bridge presentation, the baby is coming with the facing up. Also, if you have preeclampsia, those are the things that will make you go for elective CS. Emergency CS, maybe some of these emergency CS usually happen, maybe you have gone into labor and now the diagnosis of what is making you not to deliver has been made when you are already in labor, and this can be a pH, cord prolapse. I've already explained about cord prolapse, uterine rupture, cephalopelvic disproportion diagnosed in labor. Some of you don't go for gynecologist consultation, and therefore you wait until you go into labor. You come when you are 4 centimeter dilated, you cannot push. Fetal asphyxia is another thing that will make you go for emergencies. Yes. Also, a preeclampsia or eclampsia will make you go for emergencies. Yes. Cord prolapse is another one. Cord prolapse is also another one that will make you go for CS, among others. Yes, among others, I've already explained them before. So I want to advise you before I finish this video. There are some people who usually you find a mother is in labor, and maybe the doctor has diagnosed something, maybe cord prolapse, or maybe cephalopelvic disproportion in labor, or maybe breech presentation, and you have been given, you have been told that you have to go for emergencies. Yes, please don't dilly-dally, don't waste time. The doctor cannot just come from nowhere and tell you that you have to go for an emergency CS. If you've been told to go for an emergency CS and you don't know the reason why you should go for that emergency CS, ask the doctor the reason why. Ask the nurses and midwives who are taking care of you, so that they explain to you very well the reason why you are going for emergency CS. Because some of you will some patients refuse to cooperate. You tell them they're supposed to go for emergencies. Yes, they want to bring excuses. They want to tell you that emergencies, yes, in fact, we don't need someone to sign. The doctor will sign it by herself or by himself. We don't need someone to sign it. It is an emergency. We need to save your life, or we need to save the life of your life, both the life of the baby and your life. So you have to cooperate. Just ask the reason why, so that you know, and then you cooperate. You go to theater and you finish this thing. Stop this thing of dilly-dallying, wasting time, and you end up giving us maternal death, fetal death, which is not good. And you know, with maternal death, you will have to go and answer. If you're a nurse, if you're a midwife, you know very well, you will have to go and answer the questions why this mother died, why the fetus died. And especially if the mother died, you will really answer the questions why you left the mother to die. Even if it was not you, you will really have to explain. So I would advise you, if you've been told you go for emergencies, yes, please cooperate and do it. There is no reward even if you give birth through CS or through vagina. The most important thing, you are safe and the baby is safe. That's all. Any question that you will need you will want me to answer, you can put it in the comment section. So let's stop from here, and now let's meet in the next video. And in case you have any question, write it in the comment section. Bye till next time.